Good morning. I have quite a bad back today, so I'm going to lean on the lectern like a wise man. Oh, are you here? Okay. Or as my father would have said, I have a pain in the ass. Okay, so this is a talk on shortness of breath. I have an admission to make. I have a sense of humor. So this will be a sort of eclectic lecture with a bit of philosophy, music, Greek myth, and the actual discussion of shortness of breath. This didn't work too well. I'm supposed to go, I'll try going back. Yeah, here we are, dyspnea in the palliative. So this is purely in the palliative setting where we know the diagnosis ahead of time. And that changes, of course, our investigative approach. Oh, this is cool. All these effects are coming in. So who here under the age of 60 knows who Jerry Lee Lewis is? Not too many. Okay. Well, in 1958, he came out with the song Breathless, and that was the first line of it. And he was also at the same time as who's the king? Elvis Presley. But he was actually more talented than Elvis because he could actually play the piano. But anyway, there you go. So there's a picture of Jerry Lee Lewis. And as you can see, he's somewhat breathless, probably from jumping around because he was quite an active performer. So first thing you need to do, of course, in shortness of breath is look at causes. And again, in the palliative patient, infection is, I would think, the most common one. The next one is space-occupying cancer. Pulmonary embolus, of course, that's an acute shortness of breath. Pain can make you short of breath. Being delirious or agitated can make you short of breath, and of course there's always congestive heart failure in there. I forgot to put in interstitial lung disease like pulmonary fibrosis. So this is a picture of Seneca, a Roman philosopher who was sentenced to death by Nero. He was actually Nero's teacher, and the method of death he chose was a steam bath. So he died of shortness of breath. Okay. And when his wife was wailing and screaming, he said, "Why cry over part of life when the whole of it calls for tears?" There's worlds in that particular remark. Oh, back to science. So the diagnosis, you go right back to the old-fashioned way of taking a good history. When did the shortness of breath come on? Was it sudden? Was it slow? What's the cancer history, or something like fibrosis? And then there's that perhaps not as often used technique as in the old days, is the physical examination. You can learn an awful lot at the bedside. And in Toronto, where I practiced for 10 years, it was very difficult to get patients into the hospitals. The palliative care units were full, and very few of them were run like the one at Nanaimo Regional, where they could actually be used as a symptom management place. So you had to do everything pretty much on your own, and getting a patient sent to the hospital for an x-ray was usually very difficult because they were fairly immobile. And you could learn quite a lot just from listening to their chest with a stethoscope. The only exception to that is pulmonary fibrosis, because everyone sounds like they've got pneumonia when they have pulmonary fibrosis. Again, lab, there's not too much to do. I meant to ask at the beginning, what is everyone's greatest need right now? What's your greatest need? Anyone? Oxygen. So being an anesthetist, and I get teased for this, I have an oximeter in my bag. And you would be amazed at how often you get tricked. Because when you go to see a new patient and they're in a darkened room, which they often are, you can't really see the color of their skin that well. And sometimes they're not even breathing that fast. And then you put the oximeter on, and the saturation is 85%, which would correspond roughly to about 50, PO2 of 50 out of 100. So it's very important to check the oxygen saturation. Okay, does anyone know who this might be? Sir William Osler. And what is he doing? He's actually touching a patient. Isn't that something? And he was a masterful diagnostician, there's no doubt about it. So we go on to treatment now. Obviously, if there's infection, you could send a sputum off for CNS, but that takes a long time. So you need to do something in the meantime, and I put patients on azithromycin until you get the lab results, because it's quite effective in community-acquired pneumonias. If they've just come out of hospital, that's something different. You might want to put them on Cipro right away. And then when the swab results come back, you can adjust as necessary. I'm reminded of a fairly young man who had chronic lymphocytic leukemia, which had affected his lung, and he would get intermittent infections all the time. And I looked after him from April to November, and probably treated his pneumonia about 7 or 8 times. So you have to be on your toes there and always looking for that. The other thing that can make you short of breath is pure volume of cancer in the lung. And sometimes as well, if the cancer is quite inflammatory, it can cause a shunt in the blood flow, so that the blood that's coming from the heart is actually going to unventilated parts of the lung, so they become quite hypoxic. And significantly in this type of situation, the amount of oxygen you give isn't going to make a huge difference at low flows. You have to get right up to 6 to 10 liters per minute. And I suspect that's part of it, the problem with pulmonary fibrosis, because you often end up with them giving them 16 liters per minute. The other one, of course, is pulmonary embolus. Usually that's a sudden onset with or without loss of consciousness or chest pain. I think the treatment of pulmonary emboli is probably overdone, in my opinion, in palliative care, because I can't remember the risk, it's like 4% of sudden death. But if I had cancer and someone told me I might drop dead, I'd probably say that's a good thing. And yet, patients most often get treated with an anticoagulant. But I suspect if we explain quite carefully the risks, they may not go for that. And in my practice, I only use anticoagulants for patients with a lot of pain in their legs from swelling, if they've got a DVT, or weeping and exudation from the swelling. Next one, pain. Obviously, if you're really short of breath, if you're in a lot of pain, you can be quite short of breath. And obviously, the treatment there is opiates. Mentation, if someone's delirious or agitated, they can be breathing quite quickly. And as Laius pointed out quite earlier, you can treat that with antipsychotics. Speaking of treating with antipsychotics, there's quite a bit of stuff about not using those drugs in nursing homes for good reason. And we have to be careful that doesn't sort of flow over into palliative care. where they are quite appropriate a lot of the time. Cardiac, of course, someone can be in congestive heart failure, and treatment for that, of course, is quite different. You do give oxygen, but you can give some diuretics and perhaps a little bit of morphine. I don't know how many of you know that morphine still is a very effective drug for congestive heart failure because it decreases the tone in the venous system hugely. So it decreases preload and brings the Sterling curve or the point in the curve back up to optimum. Okay, anyone under 60 who knows who this man is? No one? J. Robert Oppenheimer, head of the Manhattan Project, which developed the atomic bomb. The reason I have this up here is that I'm going to just give you one slide that will blind you with science. So here's alveolar ventilation on the left side. So the higher it goes, the faster you're breathing. And the partial pressure is CO2 on the right side. As you can see in the awake state, not only do I have a bad back, but I have hearing problems, so that when you're wearing hearing aids, it sounds like you're shouting when you're actually practically whispering. Fortunately, I'm going to retire in 2 months, so I won't have to worry about that. So in the awake state, you can see that as the CO2 goes up, the amount of ventilation goes up. And with small doses of opioids, that curve is shifted to the right, but the slope remains the same. So what that means is that, is there a pointer I can use?
The top button.
Oh. It's okay, forget it. So if you choose a point on the ventilation, say the actual point where ventilation is on the line, you can see that the amount of alveolar ventilation stays the same at low doses of steroids, but the CO2 just goes up, okay? And that's quite important because if anyone says you're shortening their life by giving them morphine or whatever, you can just say that's balderdash and point them to this curve. Now in larger doses of opioids, now this is an anesthetic one, or midazolam, the curve not only shifts to the right a little bit, but the slope changes. So that means that at the larger doses, the alveolar ventilation actually does decrease. So that might cause some fairly rapid deterioration. Is that enough science for the day? Okay. Aren't these anesthetists a pain in the ass? So, obviously, morphine, hydromorphone, sufentanil. Sufentanil is quite useful for some people who just get short of breath on minimal exertion, such as going to the washroom. And I found that to be very useful. I tried using fentanyl in my early practice, but I found that it never did the job. It just wasn't strong enough. Sufentanil is about 6 to 8 times stronger than fentanyl. So if you give, depending on their age, if you give them, say, half a mil or 25 micrograms of Sufenta sublingually and tell them to wait 5 minutes, then they can often have their shortness of breath help quite a bit. If that doesn't do the job, you can go up to, actually what I tell them to do is repeat it in 5 minutes if it's not working. And then the next time they use it, they can just use a full milliliter or 50 micrograms. I had one patient used to just go through it like crazy, but it really helped her get around the house. Of course, if someone's opioid naive, we'll start with a low dose of short acting and just keep a record of that and convert it to long acting. You have to be a little careful in patients that are elderly, that's older than me. So you need to give, like say they're 80 years old, you wouldn't start with 5 milligrams of morphine, probably 2.5. And also in the older ones, or anyone really, you need to give them a pretty good talk about how it will make them drowsy for 3 or 4 days, and that will wear off. The other thing with sufentanil is some patients are quite leery about taking it. And what I try to do, if that's the case, is be there when the first dose is given, or I give the first dose. And that often breaks the anxiety. Of course, you switch to long-acting, and then once they're unable to swallow, you can go to sublingual or topical or injectable. And that's, again, where the compounding pharmacy comes. Thanks to Robin Love's work in using compounded materials, you can pretty much put anything on the skin and it will be absorbed. Sedatives, the usual. Midazolam is most commonly used in the palliative care unit. I don't like lorazepam or the benzodiazepines, because although midazolam is one, because they tend to, I think, confuse the patient quite a bit, the elderly patients. Midazolam has a problem too, because they often get tachyphylaxis to it, and you get up to huge doses quite quickly. I was going to say whoever comes up with an injectable form of quetiapine should get the Nobel Prize in medicine, because I think that's a really good one if someone's extremely agitated and short of breath. The other thing you can do is supply oxygen. There I go again with that SaO2 thing. 90 is a sort of break point for oxygen. Once you get below 90, the curve, the oxyhemoglobin dissociation curve, which I should have put here, goes down quite steeply. And so at a saturation of 90, the PO2 is 60%. So it's quite misleading. Like a small percentage can cause the actual PO2 to drop very quickly. And once you hit, just to give you an idea, 75% SaO2 is the partial pressure of venous blood. Okay. Yes, when it comes to giving narcotics for shortness of breath or pain, the anesthetic motto is sufficient is not too much. So if you're having to give big doses and they're doing the job, that's no problem. And this is Morpheus visiting a patient and helping his pain and helping him be sedated. Oh, I feel fine, thank you. So, any questions? Oh, you're probably relieved. I'm usually a fairly short presenter, so I had some time to rest. Okay, any questions about that? Yes?
Is the use of opioids for shortness of breath related to the sort of congestive heart failure model, or why would it work?
Oh, because if they're really short of breath, it slows their rate down, because it allows their CO2 to drift up, and yet they have the same ventilation, but their respiratory rate will probably be lower. Well, it is lower. So you're not shortening their life by, what I'm getting at, you're not shortening their life by doing that. I've explained.
More comfortable is what you're saying.
Well, any opiate, there's probably more complicated reasons, will slow your rate of breathing. And as I said in that slide, you don't have to worry about having their overall minute ventilation decreasing if you give them a sedative dose of morphine. So if someone says, aren't you going to shorten his life, you can say, no, we're not, until you add benzodiazepine in there. I don't think too many of you are going to give general anesthetics, no. Okay, anyone else? Good.
Well, thank you very much, John.